So I'd like to introduce our final speaker, Dr. Alan Mendelsohn is a developmental behavioral pediatrician who is Associate Professor of Pediatrics and Population Health at New York University School of Medicine and Bellevue Hospital Center. Dr. Mendelsohn's research is focused on poverty-related disparities in critical child outcomes, including child development, obesity, and chronic disease. And he will be presenting his work funded by NICHD around addressing disparities in school readiness through promotion of parenting and well child care. Thank you.
Thank you.
Yeah.
Good afternoon. It's a pleasure to be here. I'm really honored by this opportunity to talk to you about the work that I've done. Okay. So this is the problem that we have sought to address, which is that poverty-related disparities across developmental domains begin in earliest of childhood and impact educational, economic, and health outcomes throughout life. To give you an idea of the kind of statistic that underscores how significant this issue is, if one looks at disparities in reading achievement in fourth graders, as the U.S. Department of Education does, and one compares poor to non-poor children growing up in poor versus non-poor families, the percent with reading difficulties in fourth grade among poor families is approximately 44%, compared to 17% in non-poor families. We'll mention that the definition of poverty here was eligibility for a school lunch, so about twice the poverty line. This is a shocking statistic. My background is as a general pediatrician and a developmental behavioral pediatrician, in addition to being an investigator. And when one sort of thinks about the positive predictive value of poverty in predicting difficulties in school with implications through life, this is a very significant number. The guiding principles of our work has been the need for primary prevention, beginning in early childhood, where primary it means prior to the emergence of problems, that parent-child interactions can be a key target for intervention, and that pediatric primary care can be a population-scalable platform for promotion of parenting and school readiness. So what do we mean by that? Why pediatric primary care? Well, there are sort of three reasons. One is population-level accessibility. There are a lot of visits in those critical first couple of years. We're always inventing more visits, and I think a lot of that is coming from as a result of research done by NIH, in fact. And the opportunity for high engagement, the opportunity to build on parents' existing goals, existing relationships. If you ask parents what they really care about after you get past acute or chronic illness, what they really care about is their child's development and behavior. And finally, the opportunity to work at low cost, building on existing staff, infrastructure, and visits. The most studied and proven primary care intervention that is out there is called Reach Out and Read. This program includes a couple of different components. It's a very simple program. It includes waiting room volunteers and staff who model reading activities, and healthcare providers who counsel parents about the importance of reading and distribute free children's books over 5 years. What's interesting is that the experience with Reach Out and Read has really proven that pediatric primary care can be effectively utilized for population-level access and delivery of low-cost prevention. There are now more than 15 studies that show impacts, including on outcomes such as reading aloud and vocabulary. And from the perspective of dissemination and implementation, and ultimately engagement, Reach Out and Read now reaches 4.5 million children per year in the United States. And that, depending upon how you count it, would represent more than 25% of all low-income children below age 5. It does so at an estimated cost of $25 per child per year. By contrast, programs that are more intensive and highly effective, such as home visiting programs, might cost anywhere from $1,000 to $2,500 per child per year, and thus a program like this is operating at like 1/100th of that cost. And so programs like this certainly have an important role as an adjunct to more intensive programs. That being said, based on the experience of Reach Out and Read, we began to think about the idea of ways in which we might build on that model to increase impacts. And what we did is we added an interventionist or coach working one-on-one with families, promoting play and reading aloud, and in which the core activity is the video recording of parent-child interaction using a toy or book provided by the program, followed by review of the video to promote self-reflection. And this is sort of an intermediate cost, maybe $170 per child per year per our current estimates at scale, maybe 1/10 that of home visiting. Just to give you an idea of what this program looks like, we developed interactive pamphlets that build on parents' goals and structure the visit to support fidelity. And I'm just showing this to you to sort of show kind of what the structure of the visit looks like, but to note that the forms that sort of guide the structure actually contain a lot of white space. And the reason that they do is because a lot of what we're doing is we're encouraging parents to become active observers of themselves as parents and then become active participants in their child's development. So we'll ask them about what they've observed about the child, maybe trying to bring that in the context of, the child's developmental level. And then we provide a toy or book. We make plans for the video together. This is about the parents' plans. We film and review the video together with the interventionist and set goals for home. And just very briefly, I will just show you a very quick clip.
We introduce a new book or toy. Our toy for today is a book. You see that? And it's really wonderful because it gives you a lot to talk about. So it makes your interaction with her and your playtime even easier. Yeah. Because it gives you images, it gives you lots of colors, you can talk about the sound. We make a plan together for videotaping. How would you introduce the toy to her? What would you say?
Oh, I'll be like, look, Mama, a new bug, and it's very colorful. And then, like, I'll tell her how you see the sun's there. Perfect. And then, like, what color is the sun? It's yellow and orange, right? Mm-hmm.
This is a video for you and her, and it's your time together, so just play and enjoy yourself. We create a 3 to 5 minute video of the parent and child interacting together.
There. A fishy. What color is the fishy? It's pink, right? Your favorite color besides purple?
We review the video together, highlighting and reinforcing strengths in the interaction. You're constantly talking to her throughout the whole sharing of the book. You said, okay, let's open it. You're sharing now like action words. You're describing what you're going to be doing. It's pink. I love this part. You related it back to something that's very much to her. You know, it's pink, like your favorite color besides purple, because there's two, right?
It's purple.
But Jasenia, what was your favorite part of the video?
Well, my favorite part was that she was so excited to see the book. She was so into it.
Because she's excited about what you're saying to her, right? The fact that you're speaking to her in that way.
Yeah, because I noticed that she likes that.
Eventually she's going to start imitating what you're doing because to her it's fascinating. Mom is moving her mouth, a whole bunch of sounds are coming out, and I want to do that. The visit ends with a plan for reading, playing, and talking together at home. What would you like to continue doing with her at home with the book? What would you do?
The same thing, play with her, like show her the different colors. Oh, and also like I could also make up stories,
Absolutely.
So with funding from NIH and NICHD beginning in 2005, we engaged in a randomized controlled trial comparing this program to routine care and to a third program called Building Blocks, which I'm not going to go into today. And as part of the original study design, performed single-blinded assessments of parenting and child development through age 36 months. We enrolled 675 families over a 3-year period and followed children at least through age 3 in this first phase. This slide shows our published findings, which include increased parent-child interactions, including enhanced reading, play, talking, and teaching, reduced screen time, and even reduced physical punishment. I'll talk about that in a minute. Enhanced coping with psychosocial stressors. So that included sort of reduced experience of maternal depressive symptoms and reduced parenting stress. And then enhanced child development, including enhancements in language and cognitive development. But interestingly, our most robust findings thus far actually relate to social emotional development. So first, parent-child interactions. We published findings at follow-up at age 6 months showing enhancements in overall cognitive stimulation using an instrument called the StimQ, which we've not only had developed, but we've actually revalidated recently. It's available for free download on our website at NYU, and anybody can use it, to assess play with toys, reading, teaching, and verbal responsivity. Interestingly, effect sizes were fairly large at around the 0.5 standard deviation level, which is pretty big for an intervention like this. Now, we didn't seek to reduce screen time. This is kind of interesting. This was not part of our original thought process. It is now, but it wasn't then. And what we found was that we actually did reduce screen time somewhat. And what seems to be happening is that although certainly there is much data to support how screen time may displace more positive interactions, particularly in low-income households, what we believe is happening through mediation models that we've looked at is that to some extent the increase in interactions that are taking place may well be reducing some of the screen time. In addition, although we didn't focus on physical punishment, we actually found that presumably in the context of the enhanced parent-child relationship that was taking place, that there was some reduction in physical punishment, which we published last year. Second, we'll note we'll note findings related to coping with psychosocial stressors. And this is really interesting, and again, something that we weren't exactly looking for. But what we found was that there is a sustained reduction in parenting stress, again, which we think is sort of related to an enhancement in the parent-child relationship. This is a big deal. And the reason it's a big deal is because parenting stress predicts everything. But in particular, it predicts child maltreatment. And so this is actually an important finding. Third, we found some reductions in maternal depressive symptoms. And again, this isn't something that we were necessarily looking for, but which we did find. In terms of mild symptoms, a reduction from 30% to 20% approximately, and moderate symptoms from 10 to 5. Third, I'll describe briefly some of our findings related to child development. And here, I'm going to focus on these social emotional developmental findings that we've published and that we're writing up. So using the BASC subscale, which is a standardized instrument and well-validated based on parent report, we found reductions in hyperactivity, aggression, and overall externalizing behavior. The effect size in Cohen's d was around a quarter of a standard deviation, which is, again, a pretty substantial effect. Now, where it gets even more interesting is where you start to look at families who have specific social risks. So what I probably neglected to mention is that this was entirely a sample of low-income families, and all families, therefore, were at risk. That being said, some percentage of those families had additional identifiable risks, which included a prior history of mental illness or a history of homelessness or history of substance use, and those families constituted about a third of the sample. When you look at that third of the sample, the reductions in rate of clinically significant behavior problems is quite large. So to give an example of that, if one looks at hyperactivity, the rate of children meeting the sort of the first threshold for clinical risk on the BASC is actually 41% among controls at age 3 years, compared to 15% among families who were assigned to VIP. And I should mention this was all based on intent to treat. That represents a relative risk reduction of 63%, but perhaps even more relevant to policy is the number needed to treat. So the number needed to treat, as I'm sure many, if not all of you know, is related to a, is calculated based on a reduction, the absolute risk reduction. So the absolute risk reduction was a reduction from 41 to 15%. That's around a 25% reduction. And that translates to a number needed to treat of 4 for that hyperactivity measure. And what that means is that one would need to deliver this program to 4 families to actually have a reduction of 1 family who would have a child who met a clinical threshold for hyperactivity. So as you might imagine, this has direct implications for the way one thinks about policy, because it has direct monetizing implications in the sense that if you have a program that runs at $170 per child per year for 3 years, that's about $500 per family, and you deliver it to 4 families, that's $2,000 that you've given, and for $2,000 you've reduced 1 case of clinical level hyperactivity. That would be a really, really big deal. Okay, there are no 2 ways about it because of the implications across health and across the lifespan. Now, that being said, this is a 3-year measure, but as you'll see in a minute, we actually have follow-up findings that actually suggest that this continues to some extent. As we continue to follow families. Another big deal finding, and I just want to sort of highlight this, is that, here we're sort of looking at, sort of the way in which, one really new and novel finding from this has been to really begin to disentangle the ways in which the different kinds of activities and experiences that take place in families ultimately affect outcomes. And what's really interesting is that by increasing cognitive interactions, there's an interplay between those positive kinds of activities that are taking place to result in a reduction in parenting stress that then carries over to a reduction in externalizing problems. And this is a big deal because this suggests that as we look at ways to intervene with families, it's not kind of a one or the other. It's not that we promote play and reading on the one hand or we do things about toxic stress on the other. Thinking about both is probably the way to go. Now, I'll just quickly mention that we received a competing continuation from NICHD in 2010, where we re-randomized families at age 3 to get a second component of VIP called VIP 3 to 5, which families then received from 3 to 5 years or not. This enabled us to begin to look at families who received the program early, late, both, or neither, and be able to begin to say something about sort of timing and dose of intervention. Just to begin to show you some of the findings that are here, and we are very much in progress working on these findings, on these analyses, for the behavior outcome, we are finding sustained impacts of VIP 0 to 3, the 0 to 3 component, at 4.5 to 5 years, 2 years after completion of the study. And so we're finding a continuation of that quarter of a standard deviation impact. In addition, we're finding an additive impact of VIP 3 to 5, an additional independent impact of around a quarter of a standard deviation also. And so together, that's actually giving us a very big difference this is at age 54 months, of about 0.5 standard deviations. So in the last couple of slides, I want to tell a little bit about work in progress. First, I will just kind of note that we are continuing to follow the cohort to learn long-term VIP impacts. We've actually been doing school-based assessments of the cohort in second grade, and that has consisted of in-school observation of classroom engagement, teacher reports of children's achievement, and ultimately we hope to get New York State's test scores, although we have not done that yet. We've actually managed, we had to get like an individual IRB approval from like every school. Every principal had to give us individual approval. Every teacher had to give us individual approval. And we've made it into about, I forget the number, but I want to say it's about 130 or 140 schools. So it's pretty cool. Sorry, and I just mentioned that in addition, it's on the previous slide if I can go back to it, which I can't, but I'll just mention that we also have collected hair samples to assess cortisol as part of an academic pediatric association young investigator award that was sort of an add-on to begin to look more to understand pathways of stress and resilience in families. Second, I want to comment on work in progress related to dissemination and implementation. We have put in a great deal of work thinking about this issue. We've fully manualized the program. This all happened in the last 2 years. It was a lot of work. We've put together a 3-day training course for interventionists. We've designed new materials to support fidelity. We've developed a blueprint for a center of excellence to support implementation with a nonprofit business plan and organizational structure. And we have a lot of projects underway simultaneously. One of them is that the New York City Council has a New York City-wide initiative to think about promoting early literacy activities called Cities First Readers, in which VIP and Reach Out and Read are linked to the libraries. Second, we're engaged in expansion in the New York City public health hospital system through New York City Department of Health and Mental Hygiene, and expect to be implementing at Elmhurst Hospital later this year. Third, we have a new NICHD R01 in which we're called Smart Beginnings, in which we have an integrated tiered model linking VIP and primary care as primary prevention to secondary and tertiary prevention with more intensive services through family checkup in the homes of families at increased risk in Pittsburgh. Fourth, we're about to engage in implementation of VIP at Hurley Medical Center in Flint, Michigan. Happy to talk more about that. Very interesting. And finally, we're actually thinking about some international adaptations and have done some work in Brazil. I see my red light blinking. This is my final slide, which is policy implications. And just to conclude, I want to say that our findings underscore the need for primary prevention efforts for all families in poverty. Poverty alone is a significant risk, and preventative efforts are important regardless of additional factors. Second, our findings support initiatives to build on the interrelationships between the cognitive and social-emotional pathways of developmental disparities. And finally, our findings support a role for pediatric primary health care as one component of a broad public health strategy for primary prevention. I just want to thank NIH and NICHD for making this work happen. And I want to thank the members of my project team. So thank you very much for your attention.